4 days notice and no oversight. So we do feel it quite closely, and Sandy and I were working quite closely on that. But welcome to all of you. We have 3 wonderful speakers, and we are going to have them do some presentations. Then we will have an open Q&A after that. Katie Murphy, Alan Sager, and Sandy Eaton are the speakers. We thank them immensely for their expertise. And we can go ahead just to let you know, we'll do the questions in the Q&A, but it's a small group maybe. So if people need to raise their hands, you can do that. We will be recording the webinar, so it will be useful as an educational tool from any time forward. We'll be able to get that out on the website quite soon. So without further ado, Katie Murphy, another wonderful nurse, is the president of MNA. She's on the Mass Care Board, and she's been an advocate for healthcare reform for many years, 40 years, I believe, working in nursing. So we thank you for all of your leadership over time on all of these critical issues. And take it away, Katie.
Thanks so much, Bonnie, and thank all of you for being here, for having me here. I think I'll jump right in. Just to closure, I actually provided testimony to the Senate Committee on Post-Audit and Oversight, and it encompassed a lot of the same information. So now you'll know what a bunch of our legislators heard, and let's see, a lot of hospital administrators were in the room, and hospital and presidents. Very, very interesting. But so this is just to kind of talk about, a little bit of context and a little bit of the way, we as the Massachusetts Nurses Association are looking at this crisis. As I said, we want to give the MNA's perspective on the Steward crisis and what we believe should be done in response. We have a unique vantage point because we represent more than 3,000 nurses and healthcare professionals working in 8 of the 9 Steward-owned facilities. And our members deliver 90% of the clinical care patients receive in these facilities, and many have experienced working in these facilities prior to Steward's purchase of the hospitals in 2010, and as such have borne witness to all the changes wrought since their takeover, as well as to the suffering Steward's ownership and practices have caused over the last 14 years. To be clear, the loss of the facilities owned by Steward would have devastating consequences for the Commonwealth. More than 200,000 residents from the Merrimack Valley to the South Coast are served by the 9 hospitals currently owned by Steward. St. Elizabeth's in Brighton, Kearney Hospital in Dorchester, Good Samaritan in Brockton, Holy Family in Methuen and Haverhill, Morton in Taunton, Neshoba Valley in Ayer, Norwood Hospital, and St. Anne's in Fall River. These facilities have provided a health care safety net to those communities, most for over a century, delivering desperately needed care to vulnerable patients and families, including many patients and families who lack the resources to access care at other faraway medical centers. These hospitals are also among the largest employers in these communities, with more than 16,000 workers and caregivers who not only protect the public health, but also contribute to the economic health and vitality of these cities and towns. The loss of any of these facilities will deliver a devastating blow to the entire health care infrastructure in the Commonwealth, particularly to some of the most vulnerable and marginalized patients and families who will be subject to dangerous delays in care, be forced to travel longer distances for care, and for many to go without care altogether. And the impact of this and other Steward hospital closures will go well beyond any one community and prove to be catastrophic for all residents in Eastern Massachusetts, as the remaining hospitals will be forced to absorb those patients served by the Steward hospitals. This is occurring while all hospitals across the state are experiencing unprecedented overcrowding and excessive wait times for emergency care, and after the loss of 2 hospitals already,
Right.
with the flooding at Norwood and the fire at Signature Brockton. From our perspective, the entry into our state by Steward and the corporatization and the commodification of healthcare, which is the guiding ethos of all for-profit providers, has left a tale of broken promises made to those communities and the state agencies responsible for the regulation of them. It's important to point out from the outset that what has transpired is no surprise to the M&A. In fact, for well over a year, like the proverbial canaries in the mine of Steward's demise, we have been sounding the alarm to policymakers on the state and federal level of our worries about this very scenario playing out and the need to have a plan in place to deal with the fallout. From the outset, when Steward first entered the market, we testified about our concerns about what might happen if another for-profit entered our state unchecked. Massachusetts AG Martha Coakley had concerns, so she extracted promises from Steward that they agree to maintain services at those hospitals for 5 years. However, 3 years later, in 2013, Steward closed the pediatric unit at Taunton's Morton Hospital, followed a few years later by the closure of its maternity unit, helping to create what the March of Dimes has deemed a maternity desert for that region, a situation that has led to mothers, often high-risk mothers, delivering babies on Route 24 or in a Home Depot parking lot. In 2014, Quincy Medical Center was shuttered. No penalties were imposed as state officials feared a negative impact to the entire healthcare system. Steward went on to sell its hospital laboratory services to another for-profit, Quest Diagnostics, in 2014. And then in 2016, sold its hospital real estate to Medical Properties Trust. Honestly, can't make this up. So it could buy more US hospitals, as well as embark on an ill-fated expansion into Malta and other international markets, efforts that have since ended in failure and scandal. The ownership of these hospitals by Steward has meant less staff is available to deliver care. We have seen the focus on profits and private investors has meant a constant struggle to get these entities to invest in appropriate staffing. The Boston Globe reported on a tragic death of a patient in the emergency department at Good Samaritan who died of untreated heart failure, unable to be seen by nurses, overwhelmed with too many patients to care for. It has meant fewer resources and supplies needed for the delivery of care. Nurses throughout the Steward system for years have reported a daily struggle to access needed supplies, with nurses going from floor to floor looking for IV tubing or clean linens or a host of other basic supplies our staff needs to care for patients, only to be told that those supplies were on vendor hold due to lack of payment by Steward. The Boston Globe tragically also reported on the case of a specific coil that was unavailable that led to the tragic death of a mother during a complex delivery. We've watched and read the news coverage of this crisis. We have witnessed our public officials rightfully castigate Steward and heard countless rumors of what could and might be done. We've heard from the so-called experts and industry leaders, and last week we learned about a meeting that the Department of Public Health was conducting with hospital executives to discuss how they propose to handle the closure of these hospitals. The only voices not heard and the only opinions not being discussed, at least until now, are those who have the most to lose when the dust settles on this crisis, the patients and the communities who depend on these hospitals for their care. That's why the M&A has joined with other organizations to form the Our Community, Our Hospital campaign, a growing coalition of residents, community, labor, social justice, and faith-based organizations formed to make sure those in the rooms making these decisions clearly understand what is at stake in this debate. It's a new mother experiencing a complicated labor and delivery, or an elderly grandmother showing symptoms of a stroke. It is that 18-year-old student involved in a potentially fatal car crash, all of whom needing care to save their lives, when every second counts, when access to care close to home can spell the difference between life and death. While we all share outrage at this crisis, the critical task now is for all stakeholders to come together to secure new ownership of the Steward facilities and to create appropriate processes and oversight to ensure a safer, more equitable, not-for-profit healthcare system that centers patients. Failure in this endeavor is not an option that any of us should accept or tolerate. We understand this is a complex issue with no easy solutions, but if we truly live in a commonwealth, our highest priority must be to protect the common health of our residents. We call on our elected leaders and all stakeholders to do whatever is necessary to ensure the patients and families long served by Steward hospitals will continue to have access to the care and services they provide for generations to come. To do that, we need to address the gaping hole in our system that has allowed these providers to take hold in our communities, which is our state's decision in the 1990s to deregulate the healthcare system under the mantle of free market competition, with the false belief that the market alone would ensure the best care for sick people. The failure in this thinking is in placing the onus and focus on allowing the hospitals to determine how and where care will be delivered, which is often driven by who is paying for the service and how best to game the system to maximize revenue. In the case of private equity, revenue and profit is the primary focus, and the actual quality of care for the patient is at best an ancillary byproduct of those decisions. In 1960, Massachusetts had well over 100 hospitals serving a population of 5.15 million. Today, we have 67 hospitals serving a population of nearly 7 million people. Between 1980 and 2016, Massachusetts lost 31 hospitals, the county health system was eliminated, and 1/3 of the state's healthcare system was privatized or closed. Since 2009 alone, we have seen over 40 inpatient unit closures, ranging from specialty units to full-scale hospitals. In southeastern Massachusetts, Cape Cod, and the islands, we have witnessed a sharp reduction in services, including maternal health care, inpatient pediatric services, and behavioral health services. Those closures are harming our communities and leaving patients without access to necessary healthcare services. And these closures are often in areas serving economically disadvantaged populations and populations of color. The uncertain future of the Steward Network hospitals is no different, but our approach must be. We believe that we need to reverse this process and put the healthcare needs of the communities as the focus, and by extension, the specific care needs of all the patients in those communities as the starting point and the focal point of all healthcare decisions. This is something the legislature and the Healey administration prioritize. We can no longer tolerate the status quo. There must be a comprehensive assessment of the actual need for beds and services to adequately care for current and projected patient needs. There must be mechanisms in place to incentivize the maintenance of essential health services and penalize entities that eliminate those services. We must empower the Department of Public Health to take action when a healthcare entity proceeds with service closures in opposition to a DPH determination. And we must explore all options, including state receivership, for the Steward hospitals and all healthcare facilities deemed necessary to maintain health status and access. And if not receivership, communities must be allowed to preserve these vital hospitals by eminent domain. We must be proactive instead of reactive when faced with a crisis, because other crises will emerge. The question is how we will prepare for them. Perhaps this crisis can convince all of us to change the direction of the system and to finally put the needs of the communities, particularly the most vulnerable, ahead of all concerns. As such, we at the Massachusetts Nurses Association stand ready to work with all involved to ensure the continuation of all impacted hospitals for generations to come. Thank you.
Katie, thank you so much. That was brilliant. Alan Zager is with us. He is an expert, a BU professor, a health reformer, and a health economist, actually, as well, with the CHIA now as well. We appreciate Alan being here, and take it away, Alan. Oh, on mute.
I got the message. Thank you, Bonnie.
Okay.
So let's start with a quiz. Okay. I'm thinking of three very big numbers. Each of the three has a lot of zeros at the end. One of them is all healthcare spending in the United States. The other is all defense spending. And the third is all education spending. And the numbers are in a ratio of 1 to 2 to 5. So the biggest is 5 times the smallest. So which is number one? How many people think that's healthcare? Just raise your hand. Use the little yellow hand thing down at the bottom, if you can find it. It's not easy to find. Okay, how many think number one is defense? And how many think number one is all education? Okay, good. How about number 5? How many think that's defense? 5 times as big as the others.
Oh, definitely.
A lot, definitely, yeah. And how many think number 5 is education? Hands down? Not just a few. Okay, so it turns out you didn't do very well. But it turns out nobody does very well. Number one is defense. It's around 900 billion, depending on how you count. 2 is education, almost $2 trillion. And number 5 times defense spending is healthcare. And in Massachusetts, we're really number 1 in the world. This year, we're going to spend about $125 billion on healthcare in the state. State government claims that total healthcare spending is about $70 billion. So they're missing about $55 billion. But they just define that by law. And on hospitals, we're going to spend about $45 billion. So these are big numbers. $45 billion to keep open the 60 to 70 hospitals that Katie mentioned. It should be enough to keep open every needed hospital. And all healthcare spending in the state, last number, all healthcare spending in the state, $18,000 per citizen. Across all 7 million of us. $18,000 per person. That's why healthcare is the easiest problem to fix in the United States. Not easy, it's hard, but it's easier than any of the others because we spend enough. Now, we know that prevention is most people's first choice, that we should prevent what we can prevent. But it's when we're honest, we acknowledge that prevention has a 100% failure rate. And something whacks us. We get injured, we get sick, and then healthcare comes in. Of course, healthcare also has a 100% failure rate, as far as we know. Right? Healthcare has never saved a single life. That's more of a theological or a philosophical question. So what do we want from healthcare? Why are we spending $18,000 per person and spending it so badly? Partly because we're not clear on what we want. I think we want, for everybody, equitably, competent, quick, kind care without worrying about the bill and without out-of-pocket payments. Well, it turns out $125 billion is enough for that. Medical security for everybody. And that's a realistic aim, I think. So what can we do? Well, first, as Katie said, we don't have a functioning free market in healthcare. The legislature adopted free market competition because it was tired of having to adjudicate and settle fights among hospitals and payers. So they just ran screaming from the room. And the then Senate chair of the Healthcare Committee, Senator Ed Burke from Framingham, said, "Put all the scorpions in a bottle," referring to the hospitals. Apparently, he was irritated with hospitals. And of course, he had reason to be irritated with hospitals. They're confused. They don't know what they want. They're not very good at figuring out how to serve us affordably. But it turns out they've been very good at merging and gaining power for themselves and raising their prices and fighting health planning and the kind of state action that Charlie Donahue wrote about from the old Health Planning Council for Greater Boston, that he wrote about in Commonwealth Beacon a couple days ago. So we don't have a functioning free market. And that's for some people, that's kind of sad. Other people think, well, that's life. But we don't have a free market, and none of the requirements for a free market are satisfied. It just isn't available. You need 7 specific things for a free market. They're all a joke in healthcare. They're unattainable. Without a free market, there's no justification for profit. Profit only makes sense, according to many people. Profit only makes sense when you have a competitive free market, because profit then goes to people who innovate, lower cost, and give us what we need, what we're able to buy, willing to buy. That's a joke in healthcare. And everyone from Charlie Baker up and down who worships competition is just plain wrong. Now, at the same time we lack free market competition in healthcare, we've also seen, and Katie enumerated terrific examples, we also see that state government is incompetent, has proven itself to be incompetent. And starting with the deregulation, and it's not just big pharma, it's big hospitals, it's big insurance companies, and it's a lot of other groups. Pharma is certainly one of them. What state government has done is they've engaged in chronic unilateral disarmament in the face of weaponized insurance companies, HMOs, hospitals, doctor groups, drug companies, nursing home associations, and even dentists. Well, when you don't have either a functioning free market or competent government, there's only one thing left, and it's called anarchy. And I'm not talking about George Orwell's Homage to Catalonia, Anarchy in Barcelona in 1936. I'm talking about chaos. And chaos is how we spend $18,000 per person, don't deliver a lot of care that people need, close needed hospitals, in violation of law, of toothless laws, as Katie said. So what do? Well, about 30 years ago, 35 years ago, Debbie Sokolar and Peter Hyam and I were working together, and we drafted a 3-part piece of legislation. First, the state had to prepare a list of which hospitals are needed to protect the health of the public, and which services, with what capacity, what locations. Second, a real receivership law that would give the state power to intervene to protect a needed but vulnerable hospital. And these bills have been knocking around the legislature for 30 years, not moving. The last provision of the bill would have created a hospital stabilization trust fund financed by a small assessment on the hospitals themselves. In this way, state government would give itself knowledge, legal authority, and money to protect needed hospitals. And similar things could be done for primary care, dental care for everybody. We started with hospitals. Why didn't these bills get any attention? The Hospital Association worked to kill them. Insurance companies and HMOs worked to kill them. They didn't want state government to build up its knowledge or its legal authority or its ability to pay to make a difference. And when you don't know anything, when you don't have laws on the books, and when you don't have money to spend, you're incompetent. And the incompetence mirrors the political dynamics in the state, where the governor, not just this governor, but the past governor and the one before him and the one before him, didn't want to know. They didn't want to think about healthcare in a serious way. Apart from great things like Charlie Baker's serious primary care and mental health initiative, which is worth applauding. So what do we do? Well, I think we have to recognize that the governor is accountable. And she can hide behind 500 lawyers all she wants. But what good is a lawyer who's not willing to push for laws like a receivership law that would give the state the power to intervene and protect a needed hospital? It turns out that the state has a very good nursing home receivership law that allows the state to come in, take hold of a nursing home, write off inappropriately acquired debt, like the sale and leaseback and rent arrangement that Steward foisted on its hospitals. So state government is not disabled. State government is willful, again, has engaged in chronic unilateral disarmament and invited the chaos and anarchy that we suffer in healthcare. Unless somebody is held accountable, and who are the candidates? The governor, the Senate president, the House Speaker, chairs of Ways and Means, chairs of healthcare financing, many of whom know exactly what's going on. They can be held accountable. But unless we address them directly and address the president of the Mass Hospital Association, the head of Blue Cross, the head of the merged Harvard Pilgrim Tufts with its own little special weird name, unless we address them and hold them accountable and say, clean up your act, stop pretending that $18,000 per person is not enough to pay for health security for all of us. The demonstrations are good, the visibility is good, but I think the focus of accountability has to go to the governor's office and to the legislative leadership, while working to neutralize the wackos running the Hospital Association, Mass General Brigham, B.I. Leahy, Harvard Pilgrim, Tufts, Blue Cross. And they're not wackos. They're smart, decent people, but they are wrong. And they need to be reminded of that and asked to do better, asked to do serious things. Stop promising, start delivering, stop whining, start using the power available. Thanks very much.
Thank you, Ellen. We appreciate that. We're going to hold questions till the end after Sandy, and Sandy is here with us. Sandy has been a healthcare advocate, a nurse for 50 years. was oversight on the closing of Quincy Medical Center, as I had mentioned earlier. He is active with Mass Care, the campaign for single payer, as well as the labor campaign for single payer, among a variety of other medical activist groups. So take it away, Sandy.
Thank you very much, Bonnie, and thanks to you also for your service in our Quincy fight to save Quincy Medical Center nearly 10 years ago. And to Debbie Sokolar, who's on the call, I hope she's feeling better, because she also played a vital role in our unsuccessful attempt to do that. I'm so glad to be on this panel, and I'm sort of proud to be here with Katie and Alan, and I think the three of us are probably saying the same things here. So I'm going to bring us maybe a slightly sharper political edge to this, even sharper than Alan, and try to bring this down, because as we know, actions have consequences. But in Massachusetts, we have very little accountability and even less transparency into what goes on into the business. Let me just point out that the eminent domain demand that Mass Care, particularly its trade union committee, its labor committee, is injecting into this discussion, was worked out by our United Electrical Workers, UE retirees, particularly including Peter Knowlton, the retired the president emeritus of the United Electrical Workers nationally, who lives in southeastern Massachusetts and is active in our work. They tried to use the eminent domain whenever there was a plant closing. And they told me about one particular plant, I forget, it was a few years ago, in the city of Taunton, where they actually got it through the city council twice. But then the company put out that the city take over the particular plant that was closing, so that it would stay open, the jobs would stay there, and they would find a way to manage it. The company put forth such a large dollar value on it that sticker shock kept it from getting there. It required 3 votes through the city council, and it failed on the third thing. But I think I'm particularly incensed that in the last election cycle, folks, particularly labor and the rest of us, worked hard to get the so-called millionaires tax passed, and that currently and recently the triumvirate of Maura Healey, Karen Spilka, and Ron Mariano from Quincy rammed through a huge tax cut, and now folks in the public sector, in the state sector, are trying to do the best they can to take care of the patients. I have a very good friend who's in the Commission for the Blind, works for the Commission for the Blind, and he's in the leadership of Local 509, representing the workers there. And there's hiring freezes on ability to deliver care to those entrusted to them, and so this is all messed up. And I will take a little bit of an exception with Alan, that it's not just politicians throwing their hands up and walking away. There's been a plague of ideology that has led people, politicians of both major parties at all levels, have been infected with it. They call it market fundamentalism in some societies. We tend to use the word neoliberalism, but basically it's letting the market rule. And if a problem can't be solved by the marketplace, maybe it shouldn't have been solved at all. And if people fall by the wayside, it's their own weakness, their own stupidity, or their own ignorance, or their own corruption that leads to their downfall. So that mentality drives this. Also, the other factor that I want to bring in here is the encirclement by real estate developers. Now, we're all shocked. Actually, we knew in 1991, those of us that were on the Healthcare Reform Task Force of the Massachusetts Nurses Association, ably led by Dr. Judith Schindler Rothschild, recently retired from the BU School of Nursing, who got her doctorate in health policy under Steward Altman, and who's also contributed to our discussions along the way. It was very clear to some of us at that time that the privatization juggernaut was going to be paralleled by the deregulation of the private sector, which led to this cavalcade of crises, which made it the 90s. I refer to the roaring 90s, where the nurses rebelled and organized their statewide campaign for safe care, where labor largely and its affiliated groups launched MassCare, the Massachusetts Campaign for Single Payer Health Care. And then along came the docs and created the ad hoc committee to defend healthcare. And no offense to any doctors here, but we nurses had to go over and teach the docs how to organize. So there's a long history. We saw this was coming. We could predict it. We couldn't predict the specifics, but we could predict that this is what's going on. So it's not just private equity. The opening of the door to the market allowed the mergers, the creation of Mass General Brigham, for example, formerly known as Steward, which did to the folks in Lynn precisely what the private equity for-profit Steward did to Quincy. So a not-for-profit conglomerate can do just as much damage as a for-profit. So there's something underlying here. It's the whole orientation that the bottom line is all that counts, and human suffering and human need is secondary to that. We see that in the local level. We see that at the state. We see that in the country, and we see it globally. And this is at the bottom of endangering our plan. I just want to point out, more important than rehash the evils of the past, and I have a whole litany here that I could have gone into, but time is tight. I just want to point out that it might still be going on. The rally at Good Samaritan's Hospital in Brockton right now, and yesterday was a rally at Morton Hospital in Taunton, which was very thoroughly covered in the media. Channel 5 featured it last night, and the Globe and all of the local newspapers in southeastern Massachusetts and Rhode Island are covering it also. Tomorrow is still we still have 3 events going on, and I'll try if I can get them into the chat. I just want folks to be aware, and if possible, mobilize for the Fall River, St. Anne's Hospital in Fall River, the Kearney Hospital in Dorchester, and St. Elizabeth's Hospital in Brighton are the rallies that are up for grabs tomorrow. Who's going to, even if we succeed, okay, we're going to save this hospital and that hospital. Where's the low-hanging fruit? Who's going to collapse? Who's going to save the Kearney, for example? 250,000 people, extremely diverse working class community. Who's going to save that? Is Boston Medical Center, does it have the capacity? Basically, what we're saying in MassCare and many of our allies and the folks in this panel, I think, is that we need a systemic solution to a systemic problem. And I don't see that coming from the triumvirate or anyone else. Ron Mariano likes to talk about, he prefers free market solutions. Well, it's the so-called, the attempt to get a free market, agreeing with Alan on what free market means, agreeing with Alan that in fact there isn't really a free market, but pretending there is a free market is not a solution. It's that 1991 deregulation, Chapter 495 of the Acts of 1991, that opened the door, the conglomerate of not-for-profits, to the first time the entrance of for-profit chains, publicly traded corporations, like Hospital Corporation of America and Tenet, which came in and took over that sector, and which we nurses have particularly been incensed by. 301-day strike recently concluded, and the ongoing efforts to impede workers' rights there. And now and then in 2010, the think that maybe uh, private equity. And as a private equity doesn't have to report to the SEC or the others in the same way, and hence no transparency. So we have solutions. The solutions are to get out there. I'll also try to put a link in, if I'm able to, into the chat regarding a petition folks can sign to up the ante on the politicians. But ultimately, like I said, MassCare has its agenda. The Massachusetts Healthcare Trust Bill that we first filed in the late 90s and has been bottled up in committee by our Democratic Party majority in the legislature, and with no support from the Republicans when they're in the corner office. It's almost like there's a symbiotic relationship between the military, the medical industrial complex, and the political class of the state. And I'll call out the Democratic Party leadership, not the folks fighting in the trenches. Okay, I think that's enough for now. I hope there's room for a lot of discussion, a lot of questions. There's a lot of input. There's a lot of dynamic in the room I can sense. Thanks.
Good. I'm just going to check and see. Debbie, you're here. Are there any questions on the chat that you want to highlight? Or else we can just take hands from the floor. Debbie, are you there?
Sorry, I haven't been trying
Oh,
to
that's
scan
fine.
it, but I did just put one question of my own in the chat.
Oh, good. Well, tell us what that question is then.
So I'm
Oh, here you are.
hoping that Alan could elaborate a little bit more on the hospital stabilization fund idea, which in his recent comments about it that I've seen in writing have updated the potential funding source for it a bit. But also I would note that as we had conceived this is a stopgap tool to jump in crisis, and as it says, help stabilize at-risk facilities. And so clearly, it just note that clearly there need to be ongoing changes in how hospitals, especially safety net hospitals, poorer community hospitals, get funded more equitably.
Mm-hmm. Well, the governor keeps talking about what she doesn't want. She doesn't want Steward in the state, and she doesn't want the state to spend a penny to protect the Steward hospitals, doctor groups, or healthcare. Well, the idea of the Hospital Stabilization Trust Fund would be to assess 0.25% of patient care revenue each year on each hospital, plus 1% of unearned income, interest, dividend, capital gains income of hospitals, until the fund had $100 million in it. $100 million is a tiny fraction of the $45 billion that we're going to spend on hospital care in the state this year. But for a hospital that's about to go broke, it can be the difference between life and death. And we know what happens if St. E's closes in Brigham. The patients are going to try to flood the Mount Auburn emergency room, but they're backed up too. So this highlights the total lack of accountability that the governor has. She has brilliant people, terrific, smart people working for her, like Kate Walsh, who understand healthcare. I think she needs to listen to them and listen to the lawyers less, and get the knowledge, the legal authority, and the money to act. They're all available.
All righty. We have a question from Jeffrey Bartdell. Are you there, Jeff?
Yes, I am. Sorry for the delay.
Yeah.
I know I made a chat in the comment, but if you guys want to use it, you can. You can. It says lives are not expendable. You could use that to if you want to protest about this, you can use that motto.
Yeah, we couldn't agree with you more. We've got a question here from Valentina. Valentina? Are you with us, Valentina? Any other questions from the floor? I can't see everybody's hands.
Go ahead and unmute Valentina.
Oh.
Maybe Valentina will come back later. How about Mary?
Okay. Her hand is still up, so.
Yep. But she's not speaking. How about Mary Ellen?
Good, Mary Ellen.
Yeah.
I can't see. Great, Mary Ellen. Speak up.
Hi. Can you hear me okay?
Yes.
Yeah, so I actually a little struggling to have a question here, but the gist of it is that, so I'm in southeastern Mass, I'm in Fall River, and yes, we have St. Anne's that was owned by Steward. We have a second hospital in the city, and that is one of the hospitals owned by South Coast. South Coast is a nonprofit, and Sandy, you were talking about, and I completely agree with you, how nonprofits can be just as devastating in their effects as for-profit. Could you elaborate on that a little bit, and perhaps even tell us of similar nonprofits that are looking to buy or get in on the game with these hospitals that are in peril?
Well, as someone who's 50-year working at the bedside, my career has brought me, I'll say, into all of them. When I first started working at Quincy City Hospital, it was a city hospital, and then after a year or two of my being there, it brought in the Hospital Corporation of America, later split off Quorum, to manage the city hospital, this transnational for-profit corporation. In 1989, we were privatized. The mayor, like everybody else, succumbed to the ideology of market fundamentalism and cut us loose. And we became a clinical affiliate of Boston Medical Center for 10 years, and then they promptly cut us loose, drifted for 2 years, and then in bankruptcy were picked up by Steward Healthcare. So I've worked under every kind of management, and from one set of managers to the next, they became worse and worse and worse and more cruel. So we know that there's talk in the paper, and if you're down in southeastern Mass, you probably get more coverage in your local newspapers about the South Coast conglomerate wanting to take over St. Anne's. Do they have the capacity to do that? That's a possibility, I suppose. Like I said earlier, who's going to take over? I know the CEO and the board of up in, I think it's Lowell General, was sort of rubbing the hand, saying, "Oh, good, we can pick up market share if the Steward hospitals in the Pioneer Valley, in the Merrimack Valley, go under," and that's a very narrow thing. We have to realize that one hospital, like when Quincy closed in 2014, it was an immediate inundation at South Shore Hospital, for example, and the other surrounding hospitals. My wife, in the fall of 2017, had 3 occasions to need an ER, and an ICU. She wound up in 3 different ERs in 3 different communities, and I got a chance to compare how effective the staffing limitation of in ICUs that we fought for were not being carried out. So it's, and again, a couple of months ago, I had a fainting spell, and of course I was taken out of town, out to Milton somewhere. I always get lost whenever I try to go from Quincy into Milton. So again, it will be not only traumatic for the immediate community of that hospital that's being closed, but it's going to create a cascade of effects that's going to impact the whole system. We have to look at it system-wide, not just trying to pick a few of the pieces that might be able to survive, and not just to pick around the edges of what regulations are still in place. We need to approach it systematically. I am very pessimistic because I don't think, like I said, the triumvirate and the folks that call the shots in the Commonwealth of Massachusetts want to go down that route or even know how to go down that route. The current governor spent 8 years as the Attorney General. She was preceded by 8 years for Martha Coakley. Martha Coakley's, as Attorney General, Martha Coakley supposedly negotiated with Steward Healthcare when the not-for-profit hospitals, starting with the Caritas Christi, the 6 Caritas Christi hospitals from the Archdiocese of Boston, and picked up others like Morton, like Quincy, like up in Haverhill. When they got picked up, each and every time there was a negotiation, lots of promises, including the commitment to keep the facility open. In Quincy, it was for 10 years, unless after 6.5 years, they could prove that they were losing income over 2 years, and then they could have put in for, whatever. So it's effectively a 7 to 10 year commitment. No one blew the whistle.
Right.
They did not blow the whistle. We had, Debbie and I and Bonnie and others here in Quincy tried to rally the forces, but without the unions taking a decisive stand against losing Quincy Medical Center, we didn't stand a chance. Can we build the movement? Can we build the irresistible force to overcome the immovable object that is corporate control of our healthcare and the rest of our lives? I see Alan has his hand up. I don't know. I'm sorry. I'm not sure.
Alan, yeah.
Thanks, Andy. Thanks, Bonnie. I think this ties in with the second part of Debbie's initial question. When the Caritas hospitals went belly up, they were running out of money. And it may have been high cost. More likely it was payer mix, inadequate revenue. Nobody was accountable for making sure that every needed hospital could generate the revenue it required to deliver good care. And it turns out there's only one state where anybody has a list of which hospitals are needed and which emergency rooms and maternity services are needed to protect the health of the public. And that's Maryland, because Maryland has a law that says the state sets a budget for every needed hospital, and the budget has to be enough to deliver good care and keep the hospital open. That's accountability. And if Maryland can do it, they're not any smarter than we are. So there are ways to do better, because after all, we only have $45 billion that we're spending this year on hospitals. Only 45 billion. Come on.
Enid had a question in the chat. Maybe she'd like to pose it about.
Oh, good.
Well, I see one from Enid in the chat. Do you see another one, Debbie?
She was raising a question about Optum. Is she still here?
She is here. Yeah, I'll put her on.
Sorry, I'm on mute. Yeah, I'm quite familiar with Steward, having worked for 1199 and dealt with Steward for many years. I feel like the timing, like there's a timetable here. And if this Optum deal goes through, what does that mean long-term for any of these hospitals?
Some states prohibit what they call the corporate practice of medicine, where non-doctors tell doctors what to do. That might be something worth looking at, because United Health and Optum can call themselves whatever they want, but their profits are money that we pay for healthcare that we don't get as healthcare. And Optum is in the business too often of saying no. Doctors make the decisions that spend 90% of the healthcare dollar in how they diagnose and treat us. We have to put the money in their hands under arrangements that allow us to trust them to spend it carefully and intervene when they don't spend it carefully.
So could there be some oversight can the governor and the legislature put oversight on the Optum deal?
Well, I think if they were persuaded to pass a law outlawing the corporate practice of medicine, Optum would not be allowed to operate in Massachusetts, and they'd have to disgorge the doctors they've swallowed. I have no faith in this government's oversight of healthcare. Government regulation doesn't work in healthcare because the doctors and hospitals and insurance companies are too close to the patients and money, and they can justify what they want. Regulation has failed. The market has failed. The only third path forward is professionalism and building trust and holding people accountable for spending money carefully. It's only $5 trillion.
The Maryland model sounds interesting, though. Has it been tried here?
We tried a version
Legislatively?
of Maryland for
Oh, you did.
for 2 or 3 years
Yeah.
Under Chapter 372 of the Acts of '83.
Uh-huh.
Peter Hyam actually pushed that through when he was insurance commissioner. Sorry, rate-setting commissioner. But it was done badly, and the hospitals discovered they can do much better under Medicare DRGs. So they pulled out the props from under it. But it's been working in Maryland. And if Johns Hopkins can get along with it, and if hospitals in low-income neighborhoods in Baltimore can get along with it, it can work.
It sounds promising.
Let's go. Let's give Valentina Pasquantonio another.
Yes. Oh, good. Yes.
Valentina, can you?
Valentina, are you there? Her hand is still up. Valentina?
You may
Can
need
you
to unmute
unmute?
yourself.
I thought she somehow showed signs of life, but she's still not responding.
Okay. Well, are there any more questions for our panel? This has been a fascinating discussion, frustrating discussion, I might say, as
So
well.
got one from Chelsea Faria saying she's in Western Mass, Northampton, and looking for contacts in Western Mass to work on healthcare organizing. She's a peace activist, but wants to get into healthcare issues, and any contacts to be appreciated.
Mass Care. Go on to Mass Care. This very active Medicare for All Western Mass group that would be thrilled to have you participate. And Kimberly is on the call. Kimberly, you want to say something? Here's Kimberly.
Thank you, Bonnie. I appreciate that.
No problem.
It has been, once again, a very sobering and eye-opening discussion of the current state of Massachusetts healthcare system, both in delivery and in just need for professionals, need for workers, need for patients to have an equitable footing in the system, which we do not have. Mass Care is committed to making Massachusetts the first single payer state in the union. We work every year to do so. We currently have a ballot campaign initiative. We're putting Medicare for All questions on specific districts across the state. If you're interested in that, I'd put masscare.org in the chat. You can sign up there. We also will be having forums across the state. We've got 2 scheduled already, one in Shirley and one in Boston. We'll be doing other educational forums as we roll out in conjunction with the ballot initiatives, as well as keeping the elected officials' feet to the fire. This is a legislatively fixable problem, and unless they realize that, we we can't make it anywhere? Do we need to get to the point where the whole system goes under before they understand the breadth of what's going on?
Good, thank you. Katie,
You're
you
welcome.
had your hand up?
Yeah, you know what, I was trying to read everything that was in the chat because there were so many like wonderful statements and wonderful questions. But you know, and I know that the Mass Cares bill, Medicare, improved Medicare for all, has been sent to study, which in Massachusetts means it's dead. But I would recommend that everybody on this call and all your friends and neighbors just put your legislators on speed dial and then add an extra call to, as Alan was saying, to the governor, to the speaker, Ron Mariano in Quincy, and Senate President Karen Spilka, who's my senator, and just give them a call every single solitary day, because they are the gatekeepers.
That's
and
right.
and you know, nothing will happen. We, you know, we do have some legislators, for instance, I'm thinking of Senator Jamie Eldridge, who's tireless in working for Medicare for all in Massachusetts, but he can't do it alone. And honestly, I've decided that, you know, the legislators, the most important thing to them is keeping their seats. So identify yourself as a constituent, you know, and just, you know, and make that call every single solitary day. You know, the session ends July 31st. We will roll up our sleeves and start again August 1st.
That's right.
And if I could just add, Bonnie, can I add one thing?
Go right
Thank
ahead,
you, Katie.
Kimberly. Yeah, sure.
I appreciate, Katie, you reminding everyone that they sent it to study 2 days after they held a informal hearing, and we found about how much money has been robbed from the state, from the healthcare system, and from us as individuals. But the bill is not dead. Technically, the bill is not dead until December 31st. It can be revived. In fact, one of our past speakers, when he decided to take an academic job, revived a bill out of study, and it is now the law. It is codified. We have codified abortion rights as healthcare in Massachusetts because it was taken out of study in December. So we can keep them. We can keep them.
So never say die.
All right, we'll get the code card. We'll get the code card, Kimberly.
Thank you, Katie, for all you're doing.
No,
we
thank
do
everybody
have a question from Rosemary, who's asking about the issue of eminent domain option.
Yeah, and Jonathan also put a question in the chat asking about if anybody knows of successes with eminent domain or state takeover. And I have one small point to add on that, which is just that perhaps people may want to call Senator Bernie Sanders, who 5 years ago, when Hahnemann Hospital in Philadelphia was on the verge of closing, said he would file legislation to create a federal fund to assist municipalities in taking over hospitals at risk. And he never wound up doing that because a few months later, the pandemic hit. And I think there was, you know, all sorts of other money that was going to hospitals. But we could certainly stand to encourage him to take that idea up again.
Absolutely. Any thoughts on eminent domain, Alan? Yes.
Yeah. Eminent domain is one legal tool. Receivership is much more simple, much quicker. The nursing home, just look at the nursing home receivership law. I'll be happy to provide the language if people want it. The other thing, several people have asked, if we call the governor, what do we say? I think we need to say, Governor, you're in charge. You need to step up and conserve and preserve the Steward hospitals, address Enid Eckstein's point about Optum and the doctors, because if you don't have doctors admitting patients, You've got no revenue, no care, and you go belly up in 90 seconds. So Governor, Senate President, Speaker, take accountability. Stop telling us what you don't want. Tell us what you do want and how you're going to make it happen. Get the knowledge, the legal power, and the money, because without all three, you're just dead in the water. And you're just another talking lawyer.
And you know what? And I would use Alan's dollars. I would use those figures and say,
18,000. That's huge.
This is what we have in the state. Yep. We want it spent at the bedside. We want it spent at the bedside, and as politely as possible say, and I will remember this on election day, because as I've said, that seems to be their highest priority. Not all of them, you know, I'm painting with a broad brush.
Right. We have some heroes. Yeah.
Right. We really do. But, you know, I would say, you know, we spend $1.25 billion in healthcare in Massachusetts, and then nobody should be going without, or the $18,000 per person, and say, and we need you. You're my legislator. I voted for you. I live 2 blocks away from you. I need you to support this and see that it comes out of study by the end of this year.
Excellent. Any other thoughts, final thoughts for folks? Speak up if you have any comments. Sandy, yes, go right ahead.
Yeah, I just have to say that eminent domain has a powerful track record in Massachusetts. It's been used to destroy Black and brown communities to make way for interstate highways. I just read an article by someone who from Roxbury who was displaced by eminent domain. It's about time we use it as a tool. You know, I certainly appreciate Alan's receivership, but the property question is still out there.
Is quite important.
Yeah. A just healthcare system would assess each community's current and projected needs and meet them. Communities that have suffered from medical redlining, which is what I call those communities abandoned because they're not rich enough, would require reparations to attain equality with the rest of us. And healthcare disparities that are often pointed to are a result of the inequality that's inherent in capitalism. Health justice is global. Reparations to rebuild Gaza's healthcare and public health infrastructures are needed, as well as reparations to rebuild our communities, particularly communities of color that have been destroyed by marketplace orientation and so forth. So I'm very glad to be here with all of you good folks, and we've got a lot of work to do.
Well, thank you, all of you, our speakers and our participants. We will have further information. Medicare for All, Western Mass is very active. So the rep from Western Mass, look up Western Mass, Medicare for All. They're a very active group out in Western Mass. So we really, they have recruited probably more people in the state to sign on to Medicare for All bills. So yes, do follow their feed. Thank you, everyone.
There's something you can remind.
Last thoughts? Yeah.
There's something you can remind the governor too. Remember Flint, Michigan? The person there tried to save money by diverting water, and it created a crisis that's now going to cost out millions or billions of dollars. So maybe you can compare this situation to that.
Right. Penny wise, pound foolish.
Good idea.
Thank you so much, everybody. Take care and keep the fight going.
Good meeting. Thank you all.